Welcome
Got it.
to the November Talk with the Doc. Thank you for coming. Thank you, Dr. Leichliter. As always, I'll let you take it away.
Thank you, Casey. Hey guys, welcome back. For everybody who's been here before, you know the routine. For everybody who's new, if there is anybody new, I'm Dr. Leichliter. Welcome to the party. I am a so-called movement disorder specialist here at Allegheny General, sitting in my office. This is a good question and answer session for just about any questions that you have or might come up with for people with Parkinson's disease, people who take care of people with Parkinson's disease, people who know people with Parkinson's disease, people who just have random questions that they want me to answer. Knock yourself out. The best way to ask questions is to type it into the chat box. It's the one in the middle at the bottom that has a little bubble and it says chat. Type in those questions and I'll answer them as they come. I did get a few questions in email first, so I'll start with those ones, give you guys a chance to get some questions out there if you have them. Couple things that I always say when I begin. This is not a good forum to get individual treatment, right? It's not great to say, I have this, and this, I'm on this medicine. What do you think we should do next? That's a great question that you should have with your neurologist. If it's me, well, this still isn't a good place for that. Send it to me in Epic. This is a much better place to give general thoughts, ideas, so on and so forth. This is also a place to get my opinion. So everything you hear is my opinion. Generally, I think my opinion is as accurate as I can be. I think it's as based in science and literature as I can be, but sometimes there is no science or literature, and sometimes I do indeed just make stuff up, and I will indeed tell you when I'm making stuff up so that you're well aware of that. But it is just my opinion. So if you go to another neurologist or if you go to another movement disorder specialist, they may not say exactly the same thing I do. Generally, we have similar opinions, but not always the same. And without further ado, I will get started. Again, type those questions into the chat box and I will answer them as best I can. I'm going to slide that over there. All right. A couple of questions that I got in email. So what are the dangers of having Parkinson's disease and having surgery? I've heard that it increases your chances of your Parkinson's getting worse. How worse can it get? And is it a severe change? Well, that's a tough question to answer. So we do think that surgery, and in particular, it's the anesthesia. So general anesthesia, in my opinion, is not all that good for the brain. Your brain was not meant to be artificially put to sleep and woke up. And that has been shown, at least in some studies, suggestive to make neurodegenerative conditions a little bit worse or to even trigger them in somebody who's predisposed. This has been written about at least a little bit in Alzheimer's disease, and I did my own study when I was a fellow in Parkinson's disease, trying to compare people who had general anesthesia and people who had more local or spinal anesthesia. And it did look like the people who had general anesthesia, for whatever reason, did seem to have a decline in their symptoms, more so than the people who had either local anesthesia or some sort of spinal anesthesia. I don't know why. I don't understand the pathophysiology or the mechanism behind why. That's not been figured out. We don't have all the answers here, but I do see a lot of patients who come in and after they have a surgery, their symptoms do seem to get worse. A lot of times, but not all times, a lot of times people do improve afterwards. So it's almost like a kind of a dip, a transient worsening. And then as they get away from surgery and general anesthesia, their symptoms come back up to where they were before, but not always. Sometimes they don't come up at all. Sometimes they come up somewhere in between. And there's not really a good way to predict who's going to have problems and who isn't. I've never seen somebody, and this is just my personal experience, I've never seen somebody have surgery and all of a sudden they were significantly worse, or they were, dramatically, they went from up here to way down here. But theoretically, I guess it's not impossible, again, depending on the risks of surgery. And so I would say the general idea, or my general opinion, is that after surgery, you can have a mild to modest kind of decline in your symptoms. A lot of times they do rebound. Sometimes they don't. Sometimes we need more medicine after a procedure. And usually what I tell my patients is if they have to have a knee surgery or a back surgery or shoulder surgery, I usually say, they're not just going to give you a shot of whiskey and a stick to bite on, right? Not in today's medicine. And so if you need to have surgery, you need to have surgery. If surgery helps you in some way, shape, or form, if it allows you to get to exercising more, get up and moving more, have better quality of life, then you need it. There's no way around it, in which case we put up with the risks of anesthesia. And generally what that means is we kind of wait and see what happens after the fact, and then we adjust depending on what happens, how you do. And so, that's kind of my opinion on Parkinson's disease and surgery. I do not tell my patients that they can't have surgery. I do tell them to be careful around the time of surgery. So a lot of patients also tend to have hallucinations or confusion, particularly when they're in the hospital. And so there is more to it than just kind of worsening of symptoms after the procedure. But at the end of the day, these are all things that we just keep in mind, keep an eye on, and then we pick up the pieces or figure out what happens after the fact. Question number 2, I actually spent a lot of time on this morning because in between staffing patients with residents, which is what I was doing, and doing teleneurology, which is what I was doing this morning, I was looking up the answer to this question because I didn't know the answer. And so it was, do you ever treat anyone using NIR photobiomodulation offering from Well-Read? And so then, of course, I had to look up what the heck red light therapy was, or red laser therapy, or infrared laser therapy. And it turns out there is some people working on this in Parkinson's disease and a whole bunch of other stuff. And the long and short of it is no, I have never once sent anybody for this type of treatment. I didn't even learn about it till this morning, so that's probably why. The other reason, and no, I don't know everything about it, everything that's going on. So I do like it when people bring these ideas up to me so I can at least do a little bit of research and look into them. Believe me, I'm not against looking up anything or looking into anything that theoretically or might have a chance to help people do better. You might call me atypical in the medical world for that. I'm not against listening to reason. So I did look into it, and there was some suggestion that at least in animal models of Parkinson's disease, it can correct some of the dopamine depletion. It can help mitochondria work better. This idea behind red light therapy or red laser therapy or infrared laser therapy is looked at in a whole lot of things. And then I looked it up, is there anywhere around here in Pittsburgh that you can do it? And believe it or not, there are. And I went to the website for one of them that was local in Pittsburgh, and it looks like they were working on athletes or people who were busy or who had a lot of pain, joint pain, things like that. And again, take it for what it's worth. The reviews were pretty good. I tried to see if there was any studies behind this. And when you go to the Well-Read red light, man, I'm having speaking dysfunction today. Well-Read red light therapy website. They do point you in the direction of some papers that were written about red light therapy, but what I don't want to say disappointed, but not overly surprised to find is there's no real good trials in people. Shocking. Trials in people are expensive. There was a couple of case reports in people. So they basically took people who had done it and then made a case profile for each one of those and put like 6 of them together into a little bit of a paper. But again, when we're talking about medicines or when we're talking about treatments or therapies, I like to think of myself as a scientist as well as a doctor, and we like gold standard stuff, right? We like randomized controlled, placebo-controlled trials to really say for sure, yes, something is helpful. And the hard part about getting trials like that in these types of things or supplements or anything that's not mainstream medications or industry funded is they're ridiculously expensive. Now, what I also thought was interesting is they are working on that. So they're looking at this in people. And actually, I was a little bit surprised that there is a French neurologist or neurosurgeon. I can't remember if he's a neurologist or a neurosurgeon. Melibid, something. I can't remember, but he was actually one of the pioneers of deep brain stimulator surgery. In fact, he was one of the people who helped create deep brain stimulator surgery, and he's actually looking into this red light laser therapy. That's a whole lot of words to say. I'm not sure. I've never once used it. I don't know if it's effective. I'm waiting to see how it looks in people. However, it is commercially available. So you can actually go buy a hat that does red light therapy. It was about $800, or they have this intranasal one that was about $300. And again, the good part about all of these things is that it seemed very safe. There weren't a whole lot of reports of side effects or things like that. Is it going to work? I have no idea. Again, I'm waiting to hear, to see the trials that need to be done before we can say, yes, this is effective. No, it isn't, because I've been burned so many times, as you guys have been, by animal models, by phase 1, phase 2, or stage 1, stage 2 trials that look promising. And then they get to stage 3 and they're working it in people and they don't work. I mean, this has happened so many times in the Parkinson's disease community that I just don't I don't get excited when I hear something is in phase 1, phase 2 trials. It works really well in this animal model of Parkinson's disease. I say, that's great. Prove it to me in people, and then I'll get excited about it. And, you know, we've just been burned so many times by that excitement that, you know, you hate to get your hopes up that, hey, we have a new therapy, a new treatment, something that's really going to work, only to find out that it doesn't. And so that's kind of my thoughts on that. However, I did learn a lot about red laser and red light therapy this morning because it gave me a chance to read about it. And like I said, I always enjoy learning about things that are out there that I haven't heard about, particularly, you know, things like that don't hit my mainstream kind of journals that I read. And so unless somebody sends those kind of things, you know, there's no reps that are sending me messages on those or coming to me and saying, hey, what do you think about this new thing? And so again, the more you guys can send me these things, the more I'll look into it, the more I'll learn, and hopefully potentially the better I'll be able to take care of patients and you guys as well. So keep sending it to me. I'll keep looking them up. Again, my excitement is always tempered until I see better trials, but again, it's an interesting theory. Can you ever stop? I like this question. Can you ever stop yourself from dreaming? Not as far as I know. In all honesty. And the reason for that question is, as you, and a lot of you know, a lot of my patients and a lot of people with Parkinson's disease have something called REM behavior sleep disorder, which is dream enactment. So you act out dreams. Normally when people are dreaming, they're paralyzed and they can't move. Their eyes kind of dart back and forth, but that's about it. For some reason, and I am not entirely sure this has been fully worked out, people with Parkinson's disease and some of the Parkinson's-like conditions lose that paralysis. And so whereas instead of, you know, not being able to move or do anything, they end up moving around and acting out dreams and kicking and fighting and screaming and things like that and throwing themselves out of bed. So I'm assuming that's why this question was asked. But the short answer is no. I've never seen a way that you can personally stop yourself from having dreams. There are medications and things that we use for that type of behavior. Generally, you start with melatonin. Klonopin is probably the more effective, but obviously the more aggressive way to treat it. But at the end of the day, as far as I know, outside of medications, I'm not sure there's a different way to try to stop that behavior, to stop yourself from dreaming. What does it mean when you wake up frequently throughout the night and are confused, worried about spouse being there? And do you recommend any specific treatments for this? Well, that's a couple different things. So a lot of people, when they wake up, they're like, whoa, where am I? What's going on? You know, there is some confusion with the arousal state. And that's true for, I'll say, quote unquote, normal people. I don't know any normal people, but if there were normal people, they could have that too. But what I'm guessing is it's a little bit more than just, oh, what's going on? Oh, okay, I know where I'm at. Nighttime is a tough time for, you know, confusion. That can get worse. Hallucinations, delusions, illusions, all things that can come along with, you know, Parkinsonism or Parkinson's disease can be worse at night in some people. And so I'm wondering if that's what you're experiencing when you go from sleep to awake, particularly in the middle of the night, particularly several times. Now, the wondering if your spouse is there, you know, is this more of an illusion or a delusion? Tough to say. These all come along with Parkinson's disease. They all come along with the medicines. You know, it could just be regular confusion in the middle of the night, could be more ominous of a medication side effect or something more. And so I would want to delve a little bit more into that. Are there medicines or things you can do about it? Well, I mean, there's something we can do for anything. And really, it's going to come down to trying to work out what we think it is. You know, figuring out, okay, how much is this confusion? How bad is it? Is it, oh, where is my spouse? They're not here. Or is it, oh, they left me for the gardener or something like that? And all of these are legit things that I hear about and that happen. And then depending on what we think the problem is, we can figure out what to do about it. But the short answer is that's a conversation you should really have with your neurologist. Bring it up. And again, just to circle back to something that I talk about all the time on these videos is that, you know, it's really important that you bring all of these things up when you get to your doctor's office. Again, it's hard because you get such a short amount of time or a short window in the doctor's office or with the doctor. And so again, you have 50 things that you want to talk about, and you do have to kind of limit what you want to go over or pick and choose what's important. But again, these are all things that you should bring up and mention and at least at least talk about a little bit so that we, you know, if I'm your neurologist, so I can think about it, or if you have another neurologist, which you should, that they can think about maybe how big of a problem is this and how aggressive do we need to be? These are all things that we have to pick and choose what we want to work on when you're in the office. And then the last one that I got an email that came in at the 11th hour was, what are my thoughts on amantadine for freezing and festination? And so, you know, in conjunction with Cinemet, particularly in older patients, but again, all of those are neither here nor there. So freezing of gait, and let's just take a step back and explain these things, is exactly what it sounds like. So you're walking along, or you either can't get started, you stand up and you can't take a step, or you're walking along and all of a sudden you stop, you can't keep going. That's freezing of gait. Festination is similar to that, except for it's more, you take these short shuffling steps and then you get going too quickly and you break into a run. Those are really the two things that they're asking about specifically, but really my thoughts on amantadine are good. I like amantadine. Amantadine is a very old medicine. It was initially invented for the flu. It's not a very good flu medicine. It's probably not going to protect you from COVID. But at the end of the day, it was looked at in patients with Parkinson's disease, and it does have some Parkinson's disease benefit. And so it's really an add-on to Cinemet or carbidopa, levodopa. I like it because it does tend to help a little bit more with walking and balance, in my opinion. I don't think that's proven than carbidopa, levodopa, pramipexole, some of these other medicines. There's not a whole lot of good treatments for festination and freezing of gait. And so anything that might give us a little bit more benefit, I do tend to try. It also is one of the very few medicines that will help your Parkinson's, or could help your Parkinson's disease symptoms, but also lower dyskinesias. And so that's where the other place you'll see amantadine used is it tends to decrease those squirmy movements or those extra movements that you may see as a side effect of your medicine. And so the short answer is I like amantadine, and I don't have an age limit for it. I use it in everybody, you know, whoever I think it makes sense for. It has side effects. You know, we don't have a side effect-free medicine. That doesn't exist. It has its own set of side effects in addition to some of the other medicines. And so you do have to be a little bit careful with it, or at least keep an eye out for side effects. But just like every other medicine that we use, it's measuring out risks and benefits, right? We hope that the benefit of helping you walk a little bit better, being a little bit more steady on your feet, having a little bit less dyskinesia is outweighed by the potential swelling you can get in your legs, some red discoloration to your skin called livedo reticularis. It can increase vivid dreams. You know, everything we do in medicine, particularly everything I do in my office, is weighing out the risks and benefits of all of these things. And as long as it seems like it's more beneficial than risky, then it's a good choice. And that's kind of how we make our decisions. But I do use a lot of amantadine because I have seen it have good success and good benefit in the right person. And it's really kind of a personalized medicine in terms of when we're picking and choosing what we're going to do. And that was all the messages that I had in my email. And so now I will go to these questions over here in the chat box. Sorry, I was getting a text message. Do I ever recommend turning off your DBS overnight to either conserve battery or give your brain a rest? Yes and no. I know, your favorite answers from me. I'm really definitive. Well, so not in Parkinson's disease is really the answer.
This is okay, isn't it? I don't have to do it on here.
The yes part of that is in essential tremor. So we do deep brain stimulator surgery for a few different things. We do it predominantly for Parkinson's disease, essential tremor, and dystonia. Essential tremor, which is a very different kind of tremor than Parkinson's disease. In fact, it's pretty much the exact opposite of Parkinson's disease. I used to tell those patients that they could turn their DBS off at night. So in addition to you guys who also notice that your tremors and things like that probably go away while you sleep, the same is true for just about everything else. And so essential tremors, where they're not doing anything, they're sleeping, they're not shaking, they could turn their DBS off to conserve the battery. Not necessarily for brain rest. Brain rest isn't really a thing. That's a little bit of a misnomer. I don't think that's really anything we would do it for, but to conserve the battery, we used to do it because these did have a generator that you had to have in your chest. That battery had a significant lifetime. It had to be replaced after so long because the battery died. And so to conserve that battery energy, you could turn your DBS off at night. The reason why I would do it for essential tremor is because they are fairly quick to respond. So they turn it off, their tremor comes back, they turn it on, it goes away. And they don't have the other symptoms. They don't have stiffness, they don't have slowness of movement. It really is predominantly a tremor. So they could get away with turning it off at night, sleeping, they're not shaking, they get up in the morning, they turn it on, their tremor is controlled fairly quickly. Dystonia is the exact opposite end of the spectrum of that. And so dystonia is really fixed and twisting, muscle contracting, and postures. Those patients don't respond as quickly. So you turn up the DBS, it takes hours to kick in, maybe a day to kick in. You turn it off, it goes away fairly quickly, but it takes a long time for it to turn back on and affect the symptoms. And Parkinson's disease is somewhere in the middle. Some of the symptoms of Parkinson's disease go away and come back really quickly with turning it off and on, tremors in particular, but some of them don't. And so I usually do not tell my Parkinson's disease patients to turn it off at night, even though I know your symptoms go away at night. But I found that when you turn it back on, some of the symptoms don't respond as quickly or come back as quickly. And so I generally don't. And nowadays we have rechargeable batteries that last a lot longer. And so now even the battery conservation is less important in terms of turning it off at night and turning it back on in the morning. And so realistically, I don't have a lot of people doing that of any type anymore because the technology has gotten so much better. The batteries last so much longer, particularly with the rechargeables. And so the short answer is not really anymore. My husband has Parkinson's and is having intermittent problems breathing during and after moderate exercise. He's had a pulmonary function test, which revealed no problems. Does anyone else experience this? And do you have any suggestions? Well, maybe. So I do have patients who have respiratory or breathing problems with Parkinson's disease, but the trick here is figuring out what the problem is. And what I mean by that is Parkinson's disease, well, it doesn't usually affect the respiratory muscles in terms of stiffness and tremors and things like that. It's not outside of the realm of possibility. And some of the Parkinson's-like conditions like multiple systems atrophy definitely does. But I have had some patients say that they, again, shortness of breath or difficulty breathing with exercise. Now, the hard part about that is that opens the door for a whole lot of things, a heart problem, lung problem, deconditioning, muscular problem, you name it, it could be affected with that. But the other time that I've had people have a lot of breathing problems with Parkinson's diseases is a dyskinesia. So you can get a ventilatory dyskinesia, which is a side effect to the medicine. So just like you kind of get squirmy movements in your arms and legs or head, you can get this feeling in your diaphragm that really leads to a shortness of breath sensation. And so why I say the short answer to that question is it's difficult to say is we would really have to kind of delve into what's happening. What are the status of your medications? What's everything else doing when you're having this? Is it a tremor? Some people do have a diaphragm tremor, although it's not that common. Is it a dyskinesia? Is it a wearing off phenomenon and you need more medicine? Is it a side effect of the medicines and we need less medicine? So really, to truly answer that question, we would have to delve into a lot more specifics. But as a generalized kind of thing for everybody, there are some respiratory or breathing issues that can come along with Parkinson's disease. And what the last thing I want you to do is to stop exercising because of it, right? As everybody here knows, and everybody that I work with knows, and pretty much everybody that's ever met me knows, exercise is my favorite thing to talk about. And it is absolutely the most important and best medicine for everybody. And so the last thing I would want to have happen in this situation is you give up exercising because of the shortness of breath. What we should do is figure out where we think it's coming from and try to adjust or address that specifically and hopefully correct the problem so you can get back to exercise. That would be my recommendation. Do you recommend cutting back on carbidopa, levodopa if you have lost a lot of weight? Maybe. I know. I'm really good. I'm on fire today. I would not cut back carbidopa, levodopa just because you lost weight. However, if now you're on too much medicine because you lost a lot of weight, then yeah, I would. And again, that's going to come back to your symptoms. And so again, the way to think about this is carbidopa, levodopa is a symptomatic medication, plain and simple, nothing more, nothing less. It is not impacting your underlying disease progression. It is not slowing it down. It is not disease modifying. It is not curative. It is purely treating the symptoms. And when you frame the medicines that way, it's easy to answer that question. How are your symptoms doing? If you're now dyskinetic or you're hallucinating or having side effects to the medicines because now you weigh less and because it's now too potent for you, then yeah, we should cut back your medicines. But just because you lost a lot of weight, if you're still doing well and you're not having side effects to it and your tremors are controlled and your stiffness is controlled and you're walking okay, then no, I wouldn't really be in a rush to cut back the medicine. It really comes down to symptom control, how you're dealing with the symptoms, how much they're impacting your day-to-day life or how much they're bothering you. The same decisions that we always make to put you on the medicine to begin with is the same decision or decision-making process that I would use to see whether or not we should cut it back, get rid of it, think of something different. And again, sometimes that does change as you lose weight or gain weight, but I wouldn't do it just because of that fluctuation. I would really base that decision on your symptoms. Pitt was recently doing a red light therapy study regarding sleep. I didn't see that. I did see the guy in France who was doing it. I think there was somebody down in Florida who was looking at it. But the short answer is, again, I do think they're starting to look at this in people, in disease processes. And now we just have to kind of wait and see what the results are. What I read or what I looked at was that this was going to be a 3 or 4 year study. So again, the jury's still out. But believe me, if somebody publishes something or shows something that says this looks like it helps people with Parkinson's disease and they feel better, or a lot of what they talked about was the non-motor symptoms of Parkinson's disease, which we talk about all the time on this program, because they're all the things that really bother people and they're all the things that I'm not really all that good at treating. You better believe it. If somebody comes out and shows that that has benefit for people, everybody's getting red light hats or helmets or whatever they are. But I need to see the data. Then we got to get insurance to cover it because $800 is an awful lot to buy a product, particularly if we're not sure if it's going to work. And so the short answer is I'm with you guys. I am always eager to see what else is available, what's coming out, what has evidence to suggest it helps, how can we use it, how can we get it. You know, the same thing is true for a lot of the devices that come out of Europe. Everything gets approved in Europe so much quicker than it gets approved here. And so I'm always interested in what can I get, what can we use, what can we get insurance to pay for, you know, how can I help my patients the best I can. And so you better believe it. I'm always keeping my ear out, my eye out for studies, for things that suggest that they're helpful. And then believe me, as soon as we get the, yes, this does work, we're going to be talking about it a lot more. Do any or many of your patients use assistive devices like SteadyMouse, LiftWear, weighted pens, etc., and have these devices helped, aka worth the cost? I wish I could say yes, but the short answer is I haven't had too many people buy those kind of things. And the ones that have, which have been fairly few, have been kind of underwhelmed. I've been underwhelmed with the results of those kind of things. So I'm not sure what SteadyMouse is, but I can guess. It's probably a computer mouse that helps people with tremors keep it a little bit steady. LiftWear are the weighted utensils that tend to help people who shake not lose their stuff off their fork or their knife or spoon. I mean, weighted pens, again, the same idea is that when people who have tremors, if you do use weighted utensils or wrist weights or weighted pens or things like that, it will help dampen down the tremor. I've played with a few of these things. And again, my experience has been kind of iffy. They are ridiculously expensive, at least last time I checked, which hasn't been for a while. So maybe the price is coming down. But we're talking on the order of couple $100, which I think is ridiculous for utensils or you know, fancy technology things. Again, it'd be nice if you could try it before you buy it. That way, if you see that it does indeed help and you think it's worth it, go for it. I never tell people they can't look into these things or buy these things. It's just my experience has been fairly limited and kind of iffy at best. So are they worth the cost? That's subjective. I'll leave that up to you. If you can, see if you can get like a free trial and play with it first to make sure it's helpful before you buy it. That's probably my best suggestion for that. In early stage, this is a two-part question. In early stage with positive DAT scan, is it important to distinguish Parkinson's disease from Parkinsonism? Parkinsonian syndrome? Any reason to withhold Sinemet in early stages? That's a very loaded question. Let me start at the beginning. So what is a DAT scan? A DAT scan is a dopamine transporter scan. So this is not a specific test for Parkinson's disease. This purely tells you if you are in the Parkinson's family of conditions. That's why the radiologist report will almost always say positive for a Parkinsonian syndrome. Parkinson's disease falls into that category, but so do some of the other Parkinson's conditions. Things like Lewy body disease, multiple systems atrophy, things like that can also show up as positive on a DAT scan, which is why it is not a definitive or black and white test for Parkinson's disease. It does tell us that we're in the right ballpark, though. And it's basically telling us that we know you have some sort of dopamine deficiency or dopamine problem, and that's the area that we need to work on. Is it important to tell the difference between Parkinson's disease and Parkinsonism? No, and yes. So no, it doesn't change anything I do. Treatment options for Parkinson's disease, Parkinsonism, Parkinson's plus is still symptomatic, right? Again, I still don't have a disease-modifying medication, a cure, something that slows it down, something that keeps you better longer, something that alters the course. If and when we get those things, then the answer to this question is going to be very different. If and when we get disease-modifying therapies or cures or things that alter the course, then not only do I need to be more definitive and specific in my diagnosis, but we also have to be quicker to get you on those things. But we don't, that's theoretical, that's down the road. We don't have those things today. So it's not important to me if you have Parkinson's disease, progressive supranuclear palsy, multiple systems atrophy, Lewy body disease, corticobasal syndrome, drug-induced Parkinsonism, vascular Parkinsonism, any other type of and some of those won't show up as positive on a DAT scan, but you get the idea. What I do for you is no different. I still treat you symptomatically, and the decision to put you on medicine comes down to how bad your symptoms are, how much are they impacting your day-to-day life, are they keeping you from doing things? Those are my questions when I'm deciding, do I want to put you on medicine? If you have some tremors, but you're not bothered by it, it's not keeping you from doing things, I'm never in a rush to put people on medication. But if you have tremors or stiffness or slowness of movement, and it is impacting your day-to-day life, it's impacting your quality of life, it's keeping you from doing things, then yeah, I do put you on medicine. And it doesn't matter if I think those things are coming from typical Parkinson's disease, atypical Parkinsonism, Parkinson's plus. Generally, I'll start with carbidopa, levodopa. A report came out last year that suggested almost across the board that's the best drug to start with, outside of very few exceptions. And so at the end of the day, that's how we make that decision. And know that the Parkinson's disease versus Parkinsonism question does not impact my plan. It does impact how we talk. It impacts my expectations, and therefore it impacts my managing your expectations. So what I've learned a long time ago in my profession is not only do I give bad news for a living, but most of my job is expectation management. If I tell somebody that I think I'm going to give them a medicine and I think they're going to get better, they better get better, or they're not going to have a lot of trust in me, faith in me. They're not going to come back and say, hey, yeah, I know you were wrong on that one, but what do you think next, right? That's not exactly how it works. If I tell somebody that something's going to happen and it happens, that builds a lot of trust in me knowing what I'm doing. And then that person is more likely to come back and say, hey, you were right on that one. What else do you think we should do? Oh, you want me to exercise? Well, you were right the first time. Let me believe you on this one too. Let me go hit the gym and the treadmill, right? Same thing goes the other direction. If I say, look, you have Parkinsonism, you have the symptoms of Parkinsonism, but there's some red flags here. Maybe this is not typical Parkinson's disease. Maybe this is a Parkinson's plus condition. Maybe this is an atypical Parkinson's variant. I'm going to put you on some medicine because carbidopa, levodopa is still the best drug we have, but I'm not sure what's going to happen. You know, I'm not convinced that you're going to get as good as somebody who I think has typical Parkinson's disease. That's managing the expectations of that patient so that if they don't do better, they don't come back to me and say, man, you were way wrong on that one. I don't think I trust you anymore. I'm going down the street to see somebody else. And so that's really how it would impact me or you. is that if I am not convinced that you have typical Parkinson's disease, I will talk to you different than if I do. And it really comes down to trying to manage expectations because, again, as you guys all know, everybody has an expectation when they go to the doctor, they're going to get something and they may get better, or that we're going to come up with an answer for them, or that we're going to come up with a plan for them. And if I don't manage those expectations correctly, then nobody's happy. And I learned this the hard way multiple times over. I've screwed this up multiple times over, particularly when I was doing a trial for deep brain stimulators. That's when I learned the really hard way how important managing expectations is. But so a lot of what I do is talking to patients about their condition and what to expect moving forward, what to expect with what we want to do. And so that's really where it's important to try to distinguish Parkinson's disease from a Parkinsonism, which is not definitive with a DAT scan. Okay, hopefully I answered that part of the question okay. Is there any reason to withhold Sinemet in early stages? Yes or no. It comes down to how much your symptoms are impacting your day-to-day life. And this is where personalized care comes in, right? Two people who come to my office, same age, same disease, same diagnosis, are not treated the same. This is why you guys should stop talking about all the things that you're doing and they're doing and you're not doing and he's doing and she's doing, but you want to do. Everybody gets treated differently. Case in point, and this is how I explain it to my residents. If I have a 50-year-old who comes in, high pressure job, sole moneymaker for the family, insurance for the family is through him, needs his job, needs to function at a high level, I am treating that person very, very differently and much more aggressively than 50-year-old, same disease, same symptoms, is retired, watches their grandson a couple times a week, spends their days walking on the beach. Those are not the same person. Those are not the same treatment strategies. Those are not the same plan. So would I withhold Sinemet in early stages just because it's early stage? No. If your symptoms are impacting your day-to-day life, if they are keeping you from doing things, I don't care what stage you're at or what your DAT scan shows, I'm going to put you on medicine. If your symptoms aren't, if you can tolerate them, if they're not keeping you from doing things, they're not impacting your day-to-day life, they're not disabling you in any way, shape, or form, then I would hold off on putting you on medicine until it gets to that point. Again, Sinemet, carbidopa, levodopa, any of the other medicines that I have are not disease modifying. So you don't lose anything outside of kind of symptomatic benefit by waiting to take the medicine. And so that's why that's such a long answered question, because it really is complicated and it really comes down to individual treatment. And this is why they pay me, so I can make decisions like that. Is there objective evidence in delaying progression of Parkinson's disease with exercise and/or physical therapy? So this is where I have to be a little bit honest when I like to lie to people. The short answer is no. Even though I like to tell people that there is, the short answer is today, currently, there is no objective evidence that exercise delays progression of the disease. What there is objective evidence, I believe, is that if somebody is predisposed to develop Parkinson's disease, it delays the onset. And so I extrapolate, this is me, this is all my thinking. I won't blame other people, I blame me. I extrapolate that to suggest that if it does delay the onset of symptoms, it also likely delays the progression of symptoms. But there are currently a few trials going on right now to try to prove that, so we can have objective evidence, because I really do think, and this is just panned out over multiple patients that I see, tons of patients and tons of experience, that the people who exercise do better, stay better longer than the people who don't. I have to be honest and say there's not an actual objective study that says that, but I have a feeling they're coming. And the objective evidence that we do have allows me to take some liberties and extrapolate to what I think. You caught me on that one, though. You do have to be careful with amantadine. If you have kidney disease, it is cleared through the kidneys, and so there is an adjustment depending on what your kidney function is. Thank you. Is it true that a symptom of Parkinsonism, or the medication is a problem with depth perception? If so, is there testing to know how bad it is and response time? is to know if someone should stop driving or explain increased fall. That is a good question. And I am not sure I know the answer to this question. I can only tell you in terms of statistical study or significance, I can only tell you my experience on this one. And the short answer is yes. And it's not just depth perception, although I have a lot of patients with Parkinson's disease, Parkinsonism, who do have specific depth perception problems. They complain about it. They say, I go to grab something and I miss it, or I run into doors, or I run into things because I just can't measure depth perception. But there's a whole host of other vision problems that come along with Parkinson's disease and Parkinsonism, from double vision, blurry vision, difficulty tracking, difficulty reading, more than just a depth perception problem. But the short answer is yes, depth perception problem can be a problem associated with Parkinsonism as well as other vision problems. But what I don't know is I don't know if there's an actual test for depth perception problems. I would have to defer to the ophthalmologist or even a neuro-ophthalmologist to know if that's something you can actually test or measure. And that's a good question, because we all know depth perception does play a role to some extent in driving. And the reason why I say to some extent is you can actually legally drive with one eye. If you lose vision in one eye, you can still legally drive. And so even though depth perception you don't have depth perception with one eye, by the way. You need binocular vision to really have that depth perception. And so there are ways that people without depth perception can still drive, but it does bring up an important point, and not just in the increased falls, which also can happen with depth perception problem, particularly going up and down steps or running into things. But driving is something that comes up. I don't know if there's a test for it. Like I said, there's not an easy fix for it either. That I'm fairly certain of. Anything that has to do with vision, depth perception, tracking, reading, double vision, blurry vision is really hard to fix in my world. I have not had a lot of good experience treating it with medicines, treating it with prisms, treating it with surgery, glasses, you name it. They're all kind of iffy at best. And so I would defer the rest of that question, or the testing part of that question, to the ophthalmologist. But that does bring up the good question as to know, when should somebody quit driving? That's a really important question that does not have a really easy answer. I have my own way of doing it, and this is going to be all my opinion, so take it for what it's worth, particularly if you're my patients. I have a hard time figuring out when people should stop driving. It's not something that just looking at you in the office and watching you walk up and down my hall is really give me a good indicator as to whether or not you should stop driving. What I ultimately use is kind of family, friends, people who come with you. And so the way that I do it, and this is probably not true everywhere, but this is the way I do it, is, and the good part is most of my patients come with somebody else, is if everybody agrees, then we know what to do. So meaning if both people or both parties think you can drive, you can drive. If both parties think you can't drive, well, then it's obvious, then you don't drive. And everybody there is like, yep, but what happens when somebody thinks I can't drive and I think I can, right? And then it becomes a little bit of a battle, a little bit of a fight, a little bit of a complication. And I hate being the bad guy. I'm the bad guy enough. I hate being the bad guy in this case. And so when that comes up, I generally say you should go take an on-the-road test and prove to everybody that you can drive. Doesn't usually go well. People always fail. And then we have our answer. But the depth perception question of driving is a tough one. And I'm not sure there is a good test for it. But it can definitely lead to more falls and probably could lead to driving problems too. Do I recommend Sinemet and Klonopin, and what are the benefits? Well, that's a loaded question. It depends on the scenario and the situation. I use both of those medicines all the time. Sinemet being carbidopa, levodopa. This is the gold standard medicine for patients with Parkinson's disease, at least the motor symptoms of Parkinson's disease. So yes, I prescribe that 20 times a day. Klonopin is a benzodiazepine that I use at night to help people sleep. It calms down REM behavior sleep disorder, or active dreams, or vivid dreams. And so, yes, I do prescribe that a lot too, although not nearly as much as carbidopa, levodopa. And again, it always comes back to the same risk versus benefit question, right? What are we trying to accomplish, and what are the potential problems with it? Again, that's how every medical decision really should be made. And you just have to kind of bring that up with your doctor and figure out what the way you want to go. Oh, and this was my fault. What is the DBS? Is that, yeah. So I should not use abbreviations. That's my own fault. So DBS is deep brain stimulator surgery, or deep brain stimulator. And this is basically the procedure that we do for people with Parkinson's disease, where we drill holes into their head, we put wires into their brain, and we hook you up to a generator in your chest. And we can electrically block abnormal signals or correct abnormal electrical signals in the brain to, in turn, help the symptoms of Parkinson's disease. It generally works for similar things that the medicines work for. It doesn't work for similar things the medicines don't work for. And it's a surgical intervention for the treatment of Parkinson's disease. Hopefully that answered the question. I could give a whole lecture on deep brain stimulator surgery if you wanted to, but I don't want to put everybody to sleep. A lot of my Parkinson's patients have problems on the computer. You're not alone. You can blame it on Parkinson's disease if you really wanted to. A lot of my patients do not use the computer well for a variety of reasons, but your physical disabilities can also play a role in that. An interesting question. What other conditions are caused by chemical imbalance in the brain? And if not treated, could it contribute to Parkinson's? I'm thinking of some types of mental conditions. Yeah, I mean, you're probably right on that one. Generally the ones, I'm looking for the person to mute. There you are. There we go. Gotcha. Generally, the ones that we think about chemical imbalances of the brain are the psychiatric conditions. So depression, serotonin, Parkinson's disease being dopamine, although you could argue that schizophrenia is potentially the opposite end of the spectrum in dopamine. Mood disorders are oftentimes thought of to be combinations of problems with dopamine, serotonin, epinephrine. Generally, any condition you can think of from a cognitive or mental status standpoint can be some way, shape, or form traced back to a chemical imbalance. We usually think about dopamine in Parkinson's disease, but believe it or not, dopamine is not the only chemical that is not correct in Parkinson's disease. It turns out serotonin's not right, norepinephrine's not right, epinephrine's not right, so on and so forth. And so all of these chemicals are not in balance in a lot of these different conditions. And could they contribute to Parkinson's? Well, I wouldn't think that the serotonin or the norepinephrine problem in depression is then going to lead to Parkinson's. So I'm not sure if that's what you're getting at, but the short answer is a lot of these chemicals play together, and a lot of these hormonal imbalances or chemical imbalances in the brain are impacted in all of these different conditions. And that's why you see so much overlap. So 50% statistically of people with Parkinson's disease have anxiety and depression. If you take my Tourette's patients, 75 or 80% of them have ADHD or ADD. I don't know what percentage of patients with pure depression end up having some physical neurological condition, but the short answer is there's tons of overlap between all of these different things, because these chemicals don't just do one thing. Take dopamine, for example. We've been taught for 100 years that dopamine causes the dopamine loss in the substantia nigra is how you get your Parkinson's symptoms, the bradykinesia, the tremor, the stiffness, slowness of movement, so on and so forth. But it turns out it also is in the reward pathway, in the limbic pathway, which is really why we end up worrying about impulse control problems with some of the medicines. And so chemicals, fortunately or unfortunately, in the brain don't just do one thing. And so that's why there is so much overlap in a lot of these different conditions. And that also is why they're so complicated to try to control. That's why we're not great at kind of correcting the whole picture all at one time, which is really what you would need to do to try to form some form of normalcy. Again, we have a lot to learn about the brain, how it works, how it's interconnected, and how we can work on this to try to help people do better. But the short answer to that is there's a whole bunch of different chemical imbalances in the brain. And yes, like the Q1, coming back to my European comment, the Q1 is a device I'm still waiting to see, even though I've been waiting for a while, and I don't have any update on that, so we'll see how it goes. For good free virtual hand therapy, well, that's probably good for everybody. $20 weight-in pen and pencil have been pretty useful for them. Well, that's good. Again, $20 seems awfully expensive for a pen or a pencil, But if it takes somebody who can no longer write, thank you cards or notes to their grandkids or to their husband or to their son or daughter, $20 really isn't all that much if it allows you to do that, right? So it's all perspective, and it's all, relative in terms of what's too much. I do not think the Cinemet patch is close to being released yet. They've been working on a Cinemet patch for a long time. We've been looking for a lot of different non-pill medications for Parkinson's disease because of the obvious. So probably 95% of the medicines that we have for Parkinson's disease are pills, right? Everybody on this call is probably on a pill. We have the Nupro patch. We have a levodopa inhaler, or we have a thin film now that dissolves, although those last two are more rescue medicines. We have Duopa, which is an intestinal infusion. We have the surgeries, but realistically, those are the majority. I'm probably forgetting some, but those are the majority of the non-pill medicines we have. So anything that would be released in a non-pill version, a patch, something like that would be a great benefit to a lot of people, particularly people in the hospital. This is where I run into the problem the most. People who had surgery and they're not allowed to take pills, or people who have significant swallowing problems and they can't get pills in. You can imagine if you take somebody who's on 12 pills at home, which is not uncommon, they end up in the hospital, they have a surgery, they have a bowel obstruction, they have some sort of swallowing dysfunction, and now they can't take any of those medicines. You can imagine how big of a problem that is. And so the short answer is no, I haven't heard it being close to being released yet, but yes, we are eagerly waiting for other non-pill medications because it's such a big need. My leg gave out on me in the grocery store parking lot. I fell. Is this normal that one leg gives out when walking? It's not uncommon, unfortunately. So a lot of people with Parkinson's disease notice that one side's worse than the other. It's asymmetrical at onset and tends to stay a little bit asymmetrical as it progresses. And so it's not uncommon for a lot of my patients to say, one leg just gives out, or one leg's weak, or I don't pick up one leg enough to clear a curb or a step. And so that, unfortunately, that's not an uncommon description. It's just something that means you have to be very careful with that side, particularly paying attention to that side. This is where physical therapy is really helpful. Working out or exercising to try to work on that and even out that balance is really important. And so, unfortunately, that is not an uncommon story that I hear. I wish I did. Do you have recommendations for when person with Parkinson's either has apathy, and apathy is different than depression. So depression, people are upset about it, right? They don't like to do things, but they're down. Apathy is different in that people don't want to do anything. They don't like to do things they used to like to do. They don't get joy in the things they used to get joy in, but they don't really care about it. And apathy is one of the hardest things I've ever run into in Parkinson's disease to try to work on. Or denial so badly that they have no desire to learn more about the disease and what they need to be doing. Mental health medicines have helped some, but not enough. And that's what I usually run into too. Depression, in my experience, tends to respond to medicine. There's infinity medicines for depression, right? Every other day I see another advertisement for depression medicine. They don't work for apathy, at least in my experience. They just don't correct that lack of motivation, that lack of desire to do things, which is really what I see in apathy. They don't work as well. Maybe a little bit, but not much. Unfortunately, the only thing I've ever really seen to give people motivation, give people energy, give people that oomph is exercise, which is why it's one of my favorite things to talk about. But you can imagine how easy it is to get somebody who doesn't care, who doesn't want to learn about it, who doesn't want to do anything about it to exercise. It's virtually impossible. And so that's why it's such a hard problem. And that's why it's such a frustrating problem for significant others. And that's who it usually bothers the most. It doesn't bother the patients because they don't really care. It bothers the significant others. I can't tell you how many times I've heard in my office, we used to do this. We used to do this. We used to go here. I used to have trouble keeping up with them. They ran 2 businesses. We used to go to the beach. We used to go hiking. And now I can't get them to do anything. Now he just wants to sit, watch TV, and he doesn't care. I hear that story so often, hence I'm bringing it up. And it's such a frustrating thing for people on both sides dealing with it. So again, sometimes patients are bothered by it, but oftentimes not. But it's so frequently a big dissatisfier of significant others. And that in turn becomes a problem for patients. And it's just such a hard problem because I have not found a medicine. And I've tried a whole lot of things. I've tried antidepressants. I've tried stimulants. I've tried more Parkinson's disease medicines. I've tried caffeine. I've tried, you name it. I've probably tried it in somebody, and I just have not had a whole lot of success with it. I wish that somebody would come up with a solution for this problem, or a medicine that gives some benefit to it, or something that really seems to impact this type of a problem in a good way, but I just haven't seen it. So believe me, if you guys stumble across things that help with that, please do send it my way, because I have a lot of patients that fall into that category, and it's very frustrating for everybody involved. A recent paper suggests Parkinsonian signs may be seen in up to half of patients aged 80. No, that doesn't surprise me at all. We think it's about 1% of patients 60, so half by the time you're 80. So at the end of the day, what do we think drives Parkinson's disease? It's loss of dopamine. It's loss of the cells that produce dopamine. I don't want to offend any 80-year-olds out there, but you've already lost a lot of brain cells. And so at the end of the day, some of those brain cells that you've lost are the dopamine producing cells. And so just purely, my personal belief is that if we age long enough, every single person on the planet would get Parkinson's symptoms. And so that's what I think they're referring to here. Again, as you knock off cells, and with aging, you do lose brain cells. As you start knocking off or losing some of those dopamine producing cells, you will likely develop Parkinson's symptoms. And so, no, that doesn't surprise me too much. That's probably an accurate assessment. The Q1 people are dealing now with the FDA. Good luck with that. Dealing with the FDA is not the most fun thing in the world, and it takes forever. I have not read Howard Schiffke's book yet. I have gone through his blog, as I mentioned last time. So Howard Schiffke is a guy who wrote a book on fighting Parkinson's disease and winning, who, again, and I will say claims, because I don't know him, I have not met him, he is not my patient, claims he cured himself with Parkinson's disease doing Qigong and various other techniques. And so, no, I haven't had time to read anything these days. Personally, I have a whole list of books here that I really want to read, and I just don't have time and or energy to get to any of them at the moment. I'm still struggling just to get through the day most of the times. Healthcare is not a great field to be in right now in terms of having enough people to get through the day on an easy basis. I'd like to say it's rebounding, but that would be sort of a lie. We have a hard time getting people to apply and hiring people and keeping people. And so the short answer to your question is no, I haven't read the book yet. It's on my list of things to do. Eventually I will get there. I like that. I find it good music. So there is something about music therapy, believe it or not. This has been looked at. It is beneficial. And I do wonder if music therapy would help with apathy. I don't know if that's been looked at, but somebody should really look at that. And then last question, because Casey came back on, that usually means I have to wrap it up. Is could I comment on the progress of mitochondrial DNA and the future predictions of Parkinson's markers? Well, sure I can. It's not there yet. There are a couple of DNA studies going on right now. One is the generation study. I think it's run out of Harvard, but I think it's in various other places where they're still collecting data. So we're still collecting DNA data, mitochondrial DNA, other types of DNA, and trying to look back and figure out how it correlates with Parkinson's disease. What are the markers? Because as I've said before, if you're new, this will be the first time you hear me say it, our best hope for fixing this is that we have to find biomarkers, meaning we have to have accurate markers of disease, not just in accurate diagnosis, but also in disease progression, because everybody does not have the same thing. And that has to be the first step. Until we can accurately diagnose and measure disease progression, we are going to be hard-pressed finding medicines or treatments that slow down disease or fix it, because we're not comparing apples to apples. We're not treating what we think we're treating. And so that has to be the first step. And so it is a work in progress. I haven't heard anything recent on it in terms of how close we are to markers or predictors or things like that. But again, it's a work in progress. And with that, I will pass it back to you, Casey. Thanks everybody for coming in, and hopefully you learned something today. And as I always say, as long as you guys keep having questions, I will keep coming on and answering them. If we ever hit a month where nobody has a question, that's when we'll stop.
Thank you everyone for attending, and thank you, Dr. Leichliter. We have a webinar coming up on November 22nd. It's going to be a nice overview of Parkinson's by John Dean, speech and language pathologist, and Josefa Domingos, physiotherapist. We'll be sending out an email about that soon. And there's a freezing of gait webinar in December. And we will see you back here the first Thursday in December. Usually Karen lets me know of the date because I never remember.
Yeah,
I think it might be December 1st. That far ahead.
Oh, really? I barely know what I'm doing tomorrow. I can't think about next month yet.
I'm sure it's the first Thursday. Have a nice evening. Enjoy the nice weather and be well.
Have a good one, guys.
Bye.